Hello, listeners. Welcome to Discussions with Dr. G. I am your sarcastically nerdy professor and host, Dr. G. Today, we are going to start things off by getting under the hood of what we mean when we talk about psychosis. If you've ever seen someone genuinely convinced the government is tracking them by hiding bugs in their cereal boxes, or, someone hearing music blaring out of the walls, that's not just creativity running wild. Those can be textbook symptoms of psychotic disorders. So we're talking delusions, hallucinations, and that kind of classic disorganized thinking or behavior. It's a total break with reality, not just a quirky personality thing. And look, when you get into the nitty-gritty pathophysiology, it's all about brain chemistry. Dopamine is the MVP here, but not in a good way. Too much dopamine, especially in the wrong pathways, you get those positive symptoms, hallucinations, delusions, the works. Not enough dopamine, usually in the mesocortical pathway, and boom, you get negative symptoms. Flat affect, zero motivation, that sense of nothingness that's honestly just heartbreaking to see. And it's not just dopamine misbehaving either. We've got glutamate, GABA, acetylcholine. It's like this chaotic neurotransmitter potluck, and nobody brought a salad. I remember my very first clinical day as a fresh-faced student nurse. I got assigned to a patient who insisted there was jazz coming out of the radiators. I spent at least half an hour trying to listen for that music, just in case. Spoiler, there was no music. But that's the thing. The experience was 110% real for that patient. That moment is still burned into my brain because it taught me that for folks living with psychosis, their reality isn't negotiable. You work with what's real to them, not what's real to you. And trust me, the impact is massive. There's cognitive, emotional, social, even occupational impairment. And we're talking higher risk for chronic conditions such as substance use and suicide. This is heavy stuff. So how do we actually help people hit the mute button on all this chaos? Enter antipsychotic meds. Two big families here. First generation, think haloperidol, chlorpromazine, and second generation like risperidone and the ever complicated clozapine. Let's break this down quick and dirty. Typical antipsychotics. Those first-gen drugs, they hit dopamine D2 receptors like a sledgehammer. Their main claim to fame? They zap the positive symptoms, voices, delusions, that sort of thing. But they're not exactly gentle. They also block a bunch of other stuff like histamine, muscarinic, alpha-adrenergic receptors, which is basically why you get all the side effect soup. Dry mouth, constipation, urinary retention, sedation, weight gain, and my personal favorite, orthostatic hypotension. Now, chlorpromazine, for example, the king of sedation, which can be handy if someone's super agitated or can't stop vomiting. It's not subtle. Peak effect by mouth takes a couple of hours. By injection, it still takes half an hour. These meds hang around for a really long time since they've got a long half-life and the liver does the heavy lifting to metabolize them. The real party crashers? The adverse effects, like extrapyramidal symptoms or EPS. So that's dystonia, those muscle spasms that look terrifying and feel worse. Akathisia or pseudo-Parkinsonism, that shuffling gait, tremors, you name it, even tardive dyskinesia, all that tongue and facial twitching. Sometimes it's permanent. If you hear the phrase neuroleptic malignant syndrome, you basically want to hit the panic button. With this, you're going to see fever, rigidity, wildly unstable vital signs, and an altered mental status. Not fun and definitely life-threatening. Nursing priorities with first gen. Watch for EPS and NMS. Keep an eye on the EKG for QT prolongation, because who doesn't love a surprise arrhythmia? And help folks keep from taking a header off the bed because of all that sedation. Teaching-wise, nurses have to remind patients, don't stop the meds cold turkey. Manage dry mouth with water or sugar-free gum. Use sunblock because, yes, you can get a sunburn from these meds. And if anything weird crops up, fever, muscle stiffness, twitching, call right away. And please avoid mixing these with alcohol or other sedatives. You don't need the extra central nervous system drama. Trust me. Now, second generation or atypical antipsychotics, that's that risperidone and clozapine, they do things a little differently. They block dopamine, but not as aggressively. And crucially, they also block serotonin. That means they hit both positive and negative symptoms. So people not only stop hallucinating, but maybe, just maybe, they want to get out of bed and get a shower and maybe even talk to people again. Small victories, right? Okay. Overall, they have fewer motor symptoms, but they make up for it by throwing your metabolism under the bus. We're talking weight gain, new onset diabetes, cholesterol, climbing sky high. Clozapine's kind of the wild card though. Amazing for treatment-resistant schizophrenia, but you need to monitor white blood cell counts like a hawk since agranulocytosis is a real danger. Just to clarify for all my nursing students, agranulocytosis is a condition characterized by a dangerously low level of granulocytes, which are white blood cells, specifically neutrophils, eosinophils, and basophils. Clinically with atypicals, we're always checking labs and watching weight, blood pressure, and blood sugar, especially if clozapine is on board. Remind your patients about why daily, scheduled doses matter, and if they feel unwell, fever, sore throat, heart palpitations, new tremors, they need to reach out, not tough it out. Some forms are long-acting shots every few weeks, which is a lifesaver for adherence. Oh, and risperidone liquid, only mix with water, coffee, orange juice, or low-fat milk. No soda, no tea. It's one of those random things you never forget after you answer it wrong on an exam. So, you've got your meds lined up, but that's only half the story. Most of the work as a nurse is sewing safety nets everywhere, monitoring for these classic side effects like keeping a hypervigilant eye out for EPS, and seriously, never underestimating NMS. If someone on antipsychotics suddenly gets muscle rigidity, fever, or starts acting confused, drop everything because you've got to act fast. And don't forget, suicide risk assessments always stay on your radar with these disorders, no matter what. Patient education is a whole different beast. Adherence is basically an Olympic sport, especially because these meds can take weeks to really kick in. You gotta get creative. Explain dry mouth and constipation can be handled with stuff like sugarless gum or upping fiber, not just waiting it out in misery. Absolutely tell them not to combine with alcohol or other CNS depressants. And this one's big. Report fevers, confusion, or sore throat fast, and stuff like NMS and agranulocytosis are no joke. It helps to remind them how critical reporting these early warning signs can be. There was this time, oh, what a shift, where a patient on antipsychotics suddenly couldn't move his neck, started burning up, totally out of it. I remember running to track down the psychiatrist, calling the pharmacy, and we all dove in together. It was textbook teamwork, juggling rapid assessments, orders, getting IV dantrolene prepped, the whole 9 yards. That really is the core of safe care. Knowing when to sound the alarm, collaborating, and making sure everyone from the patient to caregivers knows what to look for and what to do. All right, nursing friends. That's the quick and dirty on antipsychotics today. Why dopamine's the main event, differences between first and second gens, and all those side effects. Oh, yeah. Just remember, safety is always first, monitoring is your best friend, and teaching patients is absolutely everything. I'm sure we'll dig in deeper into the rest of the psych med toolbox in a future episode. Until then, keep asking questions and don't let the dopamine gremlins win.